case of severe fibrosis, we can follow this. Another one question I would like to ask. For vitamin E, as patient comes to us with after googling, so NFL can cause HCC, and patient come to us with a lot of apprehension. So when we say we don't have any medication, so in that state, can we write vitamin E or some things other than the counseling for lifestyle modification?
As I said, patient is vitamin E or pioglitazone has to be used only in biopsy-proven NAS. And NAS is the only histological diagnosis. So this is very difficult to answer, but being a patient wants something. So because the septic concern raised with vitamin E is not so, is not based on a strong data. So I think for short period of time, 2 or 3 years, there should not be major septic concern. So it can be given.
Yes, we have enough data. Up
We
to
have
2
data
years
up
it's
to,
safe.
3 years data is available.
So we can advise 800 mg vitamin. Thank you very much.
Request Dr. Jha to felicitate Dr. Ramesh. May I request Dr. Agarwal to felicitate Dr. Jha. Request Dr. Subhas to moderate the next session, and the speaker for this is Dr. Samsad Alam. He will be speaking on the critical intersection of obesity.
Cardiology KGMC MU, Consultant Intervention Cardiologist Medanta Heart Hospital Patna. And again back to the topic of obesity, inflammation and cardiovascular disease. Over to Dr. Shamshad.
Obesity and cardiovascular disease. When I got this topic, that is clinical intersection of obesity, inflammation and cardiovascular disease, then first thought which came in my mind that apart from my regular intervention cardiology issues, what thing can I give to my listeners? So then I went into retrospect that what we have studied during our MBBS days, what we have studied during physiology, during pathology, and then all the things got compiled together, and that thing I will be presenting in front of you. So this will be the overview. This is an overview of what we are going to discuss. Without any delay, I am proceeding for this talk that cardiovascular disease and markers of systemic inflammation, they are interrelated. Whenever these markers of systemic inflammation increase, the risk of cardiovascular disease increase, such as obesity, diabetes and angina pectoris, they gradually increase. The prevalence, when we compare ourselves to our Western counterparts, so obviously we are at a higher rate of incidence of cardiovascular disease. Cardiovascular disease, it not only comprises of myocardial infarction, we have stroke, we have diabetes associated other vascular risk factors, and obviously finally when it comes to heart attack and other arrhythmias associated with it. Globally, the death rate is 235 per 1 lakh, but in India it is greater, that is 272 per 1 lakh. When it comes to age-adjusted cardiovascular mortality, then the rate is almost double. Why we are discussing this age-adjusted CVD mortality? This is because when we compare ourselves to the Western counterparts, we have on an average incidence of cardiac issues 10 to 15 years earlier than that people. That's why this is more important. So let's link this obesity, inflammation and cardiovascular disease. Whenever we have obesity, there is obvious increase in pro-inflammatory state with increase in the levels of TNF alpha, IL-6, adiponectin, and obviously the level of nitric oxide is decreased, reactive oxygen species, they are increased, and finally this all process brings us to an atherogenic milieu. And finally, atherosclerosis, insulin resistance, macrophage inflammation, hypertension, and metabolic syndrome. These are the consequences. This is a pictorial description. Whenever there is an excess calorie intake, obviously the adipose storage capacity is exceeded. This is only because lipolysis is inhibited after that. That's why when it comes to diet, the diet now it is not that much concerned about low fat diet. Now we are more concerned about low carb diet. Because with a low carb diet, the lipolysis process is going to increase and adipose tissue capacity, it will decrease further. So obviously the issues of hepatic steatosis, hepatic inflammatory response, beta cell dysfunction and insulin resistance, and finally skeletal muscle inflammatory response, these are going to decrease, and obviously this will curtail down the degree of inflammation and atherosclerosis. When it comes to inflammatory markers, we have 4 major inflammatory markers: free fatty acid, IL-6, plasminogen activator inhibitor 1 and TNF alpha. They have 2 different roles when it comes to metabolic function and when it comes to atherosclerosis. But obviously when they are altering metabolic function, they are increasing the risk of atherosclerosis. Let's say we take example of IL-6. When it comes to metabolism, it impairs insulin sensitivity, increases the risk of diabetes and as the age progresses. But when it comes to cardiology, it is secreted by macrophage. So macrophage inflammation, it increases atheromatous changes, because whenever there is increase in the activity of macrophage in the atheroscleromatous milieu in our coronaries, then obviously that patient is going to have more risk of atheroma rupture, or there is an increased risk of vulnerable plaque, and obviously the incidence of myocardial infarction increases. This is a pictorial diagram which shows the relationship between metabolic dysfunction and development of cardiovascular disease. As I said earlier, any inflammation anywhere in the body which is a systemic phenomena, then obviously it is going to affect our heart, including other vessels of the body. So obviously the risk of cardiovascular disease is going to increase, whether it comes from myocardial event, whether it comes from muscular event, adipocytes inflammation, or increased hepatic steatosis, anything, it is going to affect our heart by different pathways. So whenever we are evaluating any patient who is obese, usually nowadays we get a lot of patients who usually come for routine evaluation. I am well surprised, in last 6 months to 1 year, we have got a lot of persons even in the age group of 30 to 50 years who usually come for routine evaluation. तो हमारा सबसे पहला सवाल होता है कि परेशानी क्या है आपको? People say that no, I have come here, I do not have any disease, I am non-hypertensive, I do not smoke, I am not on any medication for anything, but I need a routine evaluation. So the simple answer to this routine evaluation is that this metabolic syndrome is the biggest thing which has to be evaluated. So initially I thought that I should send them back, but then afterwards I found that no, they have a valid query, because we can't rule out metabolic syndrome or obesity directly by seeing them in the clinic without any further workup. So these are the non-invasive diagnostic tools, and although we have a number of diagnostic modalities available, but it should be applied wisely. It is not that we get a person to get a regular health checkup and get every non-invasive test done. So the presence of mind is very important whenever we are ordering any non-invasive investigation or invasive investigation for a person who came for a routine checkup in our OPD. Starting from ECG, it is widely available and it is a routine procedure which is usually done whenever these people come to your clinic. Then there is a need of treadmill stress test, and as I said, we should be selective. It is not that TMT has to be done in every patient. Treadmill test, earlier it was said that TMT has to be done for a non-invasive investigation to rule out coronary artery disease. But from last 7 years, the guidelines have changed. as a class 1 non-invasive diagnostic modality, it has been changed into class 1 prognostic modality. Now, treadmill is not required for diagnosing coronary artery disease, but it is now required for determining the prognostic value. What is the prognosis of the patient? Because the STT changes, they are not a very big marker whether the patient has coronary artery disease or not. Even in my practice, I have seen that almost 1/3 of the patient who have STT changes on treadmill have normal coronaries. But the other thing which I have seen, that any patient who goes into stage 4 during treadmill test without any symptom, without any fatigue, obviously that patient, even if he is having coronary artery disease, the prognosis of that patient is far better than that patient without a coronary artery disease but a functional capacity of not going beyond stage 2 of treadmill test. Now, other tests such as PET, these are usually those tests which could diagnose induced reversible ischemia whenever stress is applied upon. And finally, CT coronary angiography. Earlier, before 2014, we said that the first modality should be treadmill test to diagnose whether to screen a patient for coronary artery disease. But now, CT coronary angiography is a class 1 investigation modality to screen coronary artery disease. But if the second most important thing is the pre-test probability. What is the pre-test probability of our patient? Whether, suppose if I am getting a diabetic patient, male patient especially, of the age group of 50 years, and he has typical symptoms that he has angina on exertion, then obviously I am not going to order CT coronary angiogram in that patient, because pre-test probability is already very high in that patient. In that case, you have to go for an invasive coronary angiogram. So that order of test has to be individualized. As I said, as the inflammatory markers go on increasing, whenever there is a stable plaque, it changes them into vulnerable plaque, and finally plaque rupture, which leads to acute myocardial infarction, whether ST elevation myocardial infarction or non-ST elevation myocardial infarction. These are the different risk factors. When we discuss with our patient that what are your risk factors, the most important thing is the risk of ASCVD. If the patient is male, if the age is more than 55 years, and a female of age of more than 65 years, they are not said to be premature. But in our context, if any male with less than 55 years or any female with age of less than 65 years, if he or she has developed myocardial event, a cardiovascular event, then that has to be said as a premature cardiac event. Second, the risk factor is the primary hypercholesterolemia, which has been defined as LDL level of between 160 to 189, non-HDL level between 190 to 219. Third is the metabolic syndrome, which all of stalwarts have discussed prior to me. Then chronic inflammatory conditions such as psoriasis, rheumatoid arthritis, lupus, or HIV/AIDS. Lipid biomarkers, they have been associated with the increased risk, and finally elevated hsCRP. Actually, nowadays during our OPD practices, I have seen that hsCRP is the most commonly exploited biochemical test which is being done, because people come with a bunch of tests which they have got done, and I am amazed that whether hsCRP assay has been done accurately or not, because usually the sample is collected and hsCRP assay is done on day 3rd or day 4th in a bulk. So the level of hsCRP which we get from our patient, usually we can't rely on that, because I have seen a lot of patients. Yesterday only, a 12-year-old boy, their parents brought him, his father and mother, he got his health checkup, they got their health checkup done, and also the health checkup for his kid, that 40-year-old boy, and his hsCRP levels were double of that normal range. So how did it be possible? The child was not obese, there was no family history. Family history means there should be history of premature cardiovascular event. It is not that grandfather had stroke at the age of 70 years. So it is usual. It is not that it imposes a different risk in that family. Now we have two important tests apart from the usual blood test which we usually order in our patient. One is NT-proBNP and one is HS-tropi. In advanced trial, which was usually for our diabetic patients who were put on antihypertensive treatment in the form of perindopril and indapamide, NT-proBNP level assay was done in most of the patients, and it was found that the levels of NT-proBNP help the investigators to discriminate about the 5 years risk factors of heart failure beyond that conventional risk factor. So NT-proBNP level was very useful. We should not be hesitant to order NT-proBNP level in our hypertensive patient, even if they have dyspnea, NYHA 1 or 2. This is the question behind this, why I am more emphasizing on NT-proBNP levels. It is because we are missing a lot of patients who have heart failure with preserved ejection fraction. It is a highly undiagnosed entity, especially it is more common in diabetics, and it is estimated that it is more than 50% of those patients who have heart failure. Usually whenever we say heart failure, we refer to heart failure with reduced ejection fraction, but it is quite surprising that our total heart failure patient, out of those more than 50% have heart failure with normal ejection fraction. So NT-proBNP assay is very important tool to diagnose these patients apart from symptoms. The second test which should be done is the assay of HS troponin I, highly sensitive troponin I assay, and in HighGrip trial it was found that it was a significant predictor for poorer outcomes in high risk cohorts. Whenever NT-proBNP and HS-tropi, if both of them were combined in this HighGrip trip trial, it was seen that those patients with raised NT-proBNP level as well as raised HS-tropi level, they had a poorer outcome. Now come to the weight loss trial. The overall, if there is central calorie intake, regular physical activity, and our behavioral issues are controlled, our eating behaviors, our lifestyle behaviors, we should not smoke, we should not indulge ourselves in the using of alcohols and stress related activities, then obviously we will lose our weight. Weight loss can be of two issues. One is disease related, stress related, but if we lose weight by these protocols, then obviously it is a beneficial thing when it comes to cardiovascular health. Pharmacotherapy, we have a number of drugs which can be used as a pharmacotherapy, but still as a clinician, I know most of us are not that much convinced about the pharmacotherapy for obesity. Still our patients move here and there that what can be a treatment for this obesity. So obviously, I know that pharmacotherapy can have a great impact, but lifestyle modification and control of the modifiable risk factors, they should be the first priority, and then comes the pharmacotherapy for obesity. And also, if we are putting our patients on pharmacotherapy for obesity, and even if induction of proper compliance in ongoing 3 months with weight loss of less than 5%, then obviously we need to change our way of treatment, and that pharmacotherapy is not going to help that patient if we continue on that. Lifestyle intervention has to be done for any obese patient. Counseling, proper counseling, diet modification, regular physical activity, as ADA, AHA, everyone says that regular physical activity of more than 150 minutes per week, that is 30 minutes per day for at least 5 days a week, they should be done. But it should not be limited to 5 days a week, it should be overall through 7 days or every day a week. And the most important thing, people say that मैं तो चलता हूँ 5 किलोमीटर चलता हूँ, only walking is not going to help. Brisk walking and indulging in aerobic activities, it is only going to help. Also people say that going to gym, doing 30 minutes of gym, is it going to help? Then our patients should be educated that yes, you can go to gym, but better you have to indulge yourself in aerobic activities over there, and the kind of exercise which you are going to do, Those exercises which have a risk propensity to increase diastolic pressure, which have a propensity of increasing arterial stiffness, they should be avoided. And finally, behavioral therapy, our food behaviors, our day-to-day behavior, our stress-related behavior, they have to be changed. So we emphasize a lot on weight loss. See the benefits which we get from weight loss. If we lose weight of more than equal to 5%, we have preventive approach to our diabetes. We can get good glycemic control. Urinary stress incontinence is improved. Mobility, joint pain related kind of things are improved. But when we achieve this to more than 10%, then obviously there is improvement in sleep apnea. If our patient have obstructive sleep apnea, that is going to improve, and our diabetes, which was earlier uncontrolled, they can go in remission phase with the same ongoing drug. And if we achieve that weight loss of more than 15%, then cardiovascular disease event will obviously go down. All-cause mortality is going to increase. And finally, a additive advantage which we can get from this is a reduction in incidence of cancer. It is basically due to surgical weight loss. The guidelines which say, as per the American Heart Association 2019 papers, for primary prevention of cardiovascular disease, class 1 indication is diet emphasizing on vegetables, fruits, legumes, nuts, whole grains and fish oil to decrease atherosclerotic cardiovascular disease. Replacement of saturated fats with monounsaturated and polyunsaturated fats. Diet should contain reduced amount of cholesterol and sodium. And as a part of healthy diet, it is reasonable to minimize the intake of processed meats, refined carbohydrates and sweetened beverages. But as a part of healthy diet, the intake of trans fat, it should be avoided. Whenever we are taking 0.1 to 0.5% of trans fats in our diet, it is going to harm. When it comes to overweight and obesity management, individuals with overweight and obesity, weight loss is a class 1 recommendation. Whether it should be done by counseling, it is also a class 1 recommendation. Body mass index is very important, and also as Dr. Subhas and everyone has said, that central obesity is the biggest marker than apart from body mass index. So it has a person with a body mass index of less than 25%, they can also have central obesity if we go through the proportion of the weight distribution. What are the recent strategies? It is as the government of India has included cardiovascular disease in its different programs, they say that 25% reduction in overall mortality from cardiovascular heart disease, 25% reduction in prevalence of raised blood pressure, and 30% reduction in salt and sodium intake. This is the target which has to be achieved by 2025 as the initiative taken by the Indian Hypertensive Society. We need future research, and different recommendations have been given. Lifestyle intervention through randomized control trial to identify the role of intentional weight loss and decrease visceral adiposity. It is being done. Development of dietary intervention. These are day to day. They have a lot of newer formulations. Upstream intervention for primary prevention, and whenever we get cardiovascular disease, then obviously we have to get them treated. Best practices for use of different drugs. We have newer agents like GLP-1 analogs, liraglutide. Now oral semaglutide is available. SGLT2 inhibitors are available. Whenever it comes to cardiology, and if the patient has diabetes, then people say that metformin should be the first drug to be started in diabetes. But at that place there, we say that no. Now we have the SGLT2 inhibitors as the first anti-diabetic agent to be started. It not only gives cardiovascular benefit, but it also manages those patients who have risk of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. As per the results of the recent trials in EMPA and DAPA, especially in those patients with preserved ejection fraction. And finally, effective strategies for weight maintenance. The weight loss which we have achieved, that has to be maintained. if our patient they have achieved a weight loss of more than 10%, they should be educated and counseled well so that they can maintain that weight. So let's summarize it finally. I know it was a very haphazard kind of topic. I was, as a speaker, I thought that I may go here and there. But finally, let's summarize. Obesity, it is recognized as a heterogeneous condition in which individuals with similar BMIs may have distinct metabolic and cardiovascular disease profile. Numerous studies, they have been demonstrated that circulating mediators of inflammation, they participate in mechanisms of vascular insert and atheromatous changes. And further future researches are on the potential pathophysiological mechanism which can link cardiovascular disease to systemic inflammation is necessary to improve knowledge on prognostic value of cardiac biomarkers in these patients. Thank you.
Thank you, Dr. Sajjan. You have done justice to the topic because we have learned a lot of new insights regarding the risk of obesity and cardiovascular.
Came to my clinic. So before advising him to do regular physical exercise, any cardiac test is recommended. He is asymptomatic regarding the cardiac illness. Advise him to do regular exercise is required.
We should first of all have an assessment of what is the functional capacity of that patient, which we usually get through the history. As I said that in diabetics and hypertensive, the incidence of heart failure with preserved ejection fraction is very high and it is usually underdiagnosed. But as per the newer recommendation, as per the newer definition for diagnosis of heart failure, it is not only biochemical related. We need to test for anti-proBNP level only if the patient is symptomatic. And second thing, on echocardiogram, if the patient is having the changes which are related to heart failure with preserved ejection fraction. If that diabetic patient is doing well, his hypertension is well controlled, he is having no symptoms of any dyspnea, he has a very good functional capacity, he can walk for 4 to 5 kilometers, then obviously I am not going to evaluate him further on. Yes, people say that, and basically baseline echocardiogram has to be ordered in any diabetic hypertensive patient at least once.
Now, recently I have seen not many people having sudden MI at gym, and younger people without any history of diabetes and they're doing well and suddenly they collapse. So do we need to advise some exercise, some tests before we send them to gym, or younger people asymptomatic, no history?
No, family. If there is no history of syncope or pre-syncope or any kind of dizziness in that person or in any of his siblings, then obviously some diseases we can easily rule out, such as if the association of hypertrophic cardiomyopathic associated cardiac arrest, that is most common thing which we usually get in younger patients especially. This is because whenever we inquire in detail about the history, we can find that whether a history of syncope or pre-syncope is there, which has been not diagnosed or that person has not reported that, or any similar symptom had occurred in the family. Apart from this, as a routine investigation, there has been no recommendation if there is no family history of these kind of events.
Thank you.
So we have all the specialties like endo, then we talked about cardio, then we go to gastro. So let's hear from a different perspective, the nephro perspective, the CKD diabetes. Now to deliver this talk, may I invite Dr. Anil Jaiswal and to moderate Dr. Prithpal Singh. Dr. Prithpal Singh, may I request you to please come and moderate this session.
Now learned about diabetes and CKD. Obviously, almost 40% of the diabetics do have diabetic nephropathy, and better say diabetic kidney disease. And as this is going to be the largest pandemic, obviously kidney diseases are of a bigger concern. So I invite Dr. Anil Jaiswal to deliberate this session, CKD in diabetes.
Me here for this for this program today. Today I will be delivering on an updated overview of diabetic nephropathy. So, diabetic nephropathy is defined as specific pathologic, structural and functional changes seen in kidney of patients with diabetes that results from the effect of diabetes on kidney, resulting in a presentation that is characterized by proteinuria, hypertension and progressive reduction in the kidney function. So diabetic kidney disease is the leading cause of CKD worldwide, and according to 2012 Indian CKD registry, diabetic kidney disease is the leading cause of CKD in India as well, accounting for about 31% of the total cases. About 30 to 40% patients with diabetes will eventually develop nephropathy, and the risk of development of CKD is equal in both types of diabetes. Coming to the pathology, in diabetic patient, the diabetic milieu in the kidney results in generation of advanced glycation end products, formation of some growth factors and hormonal changes, along with some hemodynamic changes that results in glomerular hyperfiltration, glomerular hypertension, renal hypertrophy, along with deposition of extracellular matrix in the mesangium, which ultimately progress to glomerulosclerosis and interstitial fibrosis. Coming to the risk factors for diabetic nephropathy, the most important risk factor is proteinuria and duration of diabetes, along with hypertension, which predicts the progression to end-stage kidney disease. Other significant risk factors are genetics, age, race, level of glycemic control, smoking, dietary factors such as intake of salt, intake of amount of protein and fat, etc. The natural history of diabetic nephropathy is well studied in type 1 diabetes. Basically, it has got 5 stages. In the first stage is the stage of glomerular hyperfiltration and hypertrophy. In this stage, there will be increased eGFR. The kidney size will increase about to 15% of the original size and volume, and there will be no excretion of significant protein in the urine. This is followed by the silent stage, in which still the GFR will be on the higher side, and there will be structural changes in the kidney which will be evident in biopsy, but the patient will be more or less asymptomatic and there will be no significant proteinuria. Then comes the incipient stage, in which the increased GFR normalizes, the structural changes will be evident there. At this stage only, the patient will start having high blood pressure and passage of significant amount of urine in the significant amount of protein in the urine. This is followed by stage of overt nephropathy stage. This is where the eGFR starts to decrease and serum creatinine will start to increase, and the proteinuria will be significant and that will be gross, and this is accompanied by retinopathy, and once the GFR has decreased, this will relentlessly decrease and progress to 5th stage of the diabetic nephropathy, which is end-stage kidney disease. Coming to the clinical approach to diagnosis of diabetic kidney disease. Diabetic kidney disease is a clinical diagnosis which is based on detection of proteinuria, serum creatinine concentration and GFR estimation, ophthalmological examination, and ruling out other alternative kidney disease. Kidney biopsy is only performed when an alternative renal pathology is suspected. ADA and KDIGO recommends that in type 2 diabetes, renal function and albuminuria should be measured at the time of diagnosis and thereafter annually. And in type 1 diabetes, this can be done after 5 years of onset of diabetes. And EGFR calculation based on CKD EPI equation should be done. Measuring only serum creatinine could misrepresent the actual EGFR. For example, let's say a patient who is a 60-year male and his creatinine is 1.3. So the level of creatinine might appear innocuous, but when we convert that into a EGFR, that will be significantly low and will be categorized as CKD3 or somewhere 2. Albuminuria is best assessed using albumin-creatinine ratio measurements on spot urine sample, and the sample should be ideally the first morning void sample. Timed or 24-hour urine collection to measure albumin are also appropriate. However, this requires accurate collection over a period of 24 hours, which could be cumbersome, and this is prone to errors. KDIGO have categorized the proteinuria into 3 categories, that is normal to mildly increased proteinuria, moderately increased proteinuria and severely increased proteinuria based on the amount of protein passed in the urine. So the proteinuria can be quantified based on albumin excretion rate, protein excretion rate, or in a spot sample doing albumin creatinine ratio or protein creatinine ratio. Urine routine using protein reagent strip for quantification of protein is not very accurate. So once we have detected a reduction in EGFR or increase in albuminuria is detected, this has to be confirmed on repeated testing over a period of 3 to 6 months. A minimum of 2 elevated albumin creatinine ratio levels more than 3 months apart are required to label somebody as having diabetic kidney disease. Similarly, 2 GFR values less than 60, 90 days apart are required to make a diagnosis of diabetic kidney disease. We have to rule out transient causes of proteinuria such as postural proteinuria, urinary tract infection, hematuria. Even high dietary protein intake can lead to proteinuria. Similarly, congestive cardiac failure can lead to proteinuria. Menstrual or vaginal discharge and drugs such as NSAIDs can cause transient proteinuria. So we have to look for persistent of proteinuria in urine over a period of time to label somebody as having significant proteinuria. So what's the role of diabetic retinopathy in diagnosis of diabetic kidney disease? Almost 95% of patients with type 1 diabetes and diabetic nephropathy also have diabetic retinopathy. So absence of retinopathy in a patient of type 1 diabetes imply there could be some alternative pathology. On the contrary, only 60 to 65% of patients with type 2 diabetes and diabetic nephropathy have diabetic retinopathy. So absence of retinopathy in such patients do not generate a high negative predictive value. It can even be diabetic kidney disease even in the absence of retinopathy in type 2 diabetes. So in type 1 diabetes, diagnosis of diabetic kidney disease can be done if there is persistent, moderate or severe albuminuria and or persistent reduction in EGFR to less than 60 along with diabetic retinopathy and no any features suggestive of alternative kidney disease at least 5 years after the onset of disease. In type 2 diabetes, same principle applies. However, longer duration of diabetes and presence of retinopathy are important pointer towards the diagnosis when they are present, but neither a short duration of diabetes nor the absence of retinopathy are useful to rule out diabetic kidney disease in type 2 diabetes because the onset of disease in type 2 diabetes is not very clear. When should we suspect alternative cause of kidney disease in patient with diabetes? So these are when somebody presents with nephrotic range proteinuria or kidney failure in the absence of diabetic retinopathy. Nephrotic range proteinuria or kidney failure with diabetes of less than 5 years duration. Somebody who develops nephrotic range proteinuria with normal kidney function. Presence of active urinary sediments such as red cell cast or dysmorphic RBCs suggests that the renal pathology could be other than diabetic kidney disease. If there is rapid decline in EGFR or sudden onset of albuminuria in a previously stable kidney function, and if there is concomitant systemic disease that can cause kidney disease. In this situation, we need to do renal biopsy to ascertain that this is because of some other pathology. In a study, it has been shown that the pathological diagnosis other than diabetic nephropathy are found in more than half of patients with type 2 diabetes with proteinuria. So the major pathologies are FSGS, minimal change disease, possibly vasculitis and membranoglomerulonephritis. Non-albuminuric diabetic kidney disease is a increasingly recognized entity, and this accounts for up to 25% of diabetic kidney disease in patients, especially with type 2 diabetes. Generally, the etiologies that are ischemic in nature or on which tubulointerstitial pathology predominate causes non-albuminuric diabetic kidney disease. However, non-albuminuric diabetic kidney disease has also been seen with typical histopathological changes of diabetic glomerulopathy. So this phenomenon could be explained because of the impact of long-term RAS inhibitor. Somebody who is on long-term RAS inhibitor, they might develop pathological changes of diabetes in the kidney, however they won't pass protein. Similarly, somebody who has unresolved undiagnosed acute kidney injury or somebody who has got coexisting vascular disease or tubulointerstitial fibrosis, they will have diabetic kidney disease with increased creatinine and no proteinuria. So non-proteinuric diabetic kidney disease overall has a better prognosis, has less severe pathological lesions, low blood pressure and much better 5-year CKD survival compared to the albuminuric diabetic kidney disease. So non-albuminuric diabetic kidney disease has a better prognosis compared to the albuminuric diabetic kidney disease. Various differential diagnoses that has to be considered in case of non-albuminuric diabetic kidney disease are ischemic nephropathy, dysproteinemia related renal disease, tubulointerstitial nephritis and previous episode of AKI which has unresolved. Ischemic nephropathy should be strongly suggested if somebody has a vascular lesion elsewhere, somebody has a aortic disease, or there is a asymmetrical kidneys on ultrasound finding and there is a large decline of EGFR after the initiation of RAS. In such situation, we have to strongly suspect ischemic nephropathy. Coming to the treatment of diabetic kidney disease, it can be divided into 5 major arenas. The first is the glycemic control, second is the inhibition of RAS, third is the blood pressure control, fourth is the SGLT2 inhibition, and fifth is the cardiovascular risk reduction. Talking about the importance of glycemic control in diabetes, in type 1 diabetic patient, 2 landmark trials, DCT and EDIC trials. In this type 1 diabetic patient were randomized to either intensive therapy group and conventional therapy group. The intensive therapy group achieved a mean HbA1c of 7.3%, whereas the conventional therapy group achieved the mean HbA1c of 9.1%. It was found in the intensive care group that there was decreased microvascular complications including microalbuminuria, proteinuria, retinopathy and neuropathy. Thus, this highlights the importance of glycemic control in patients with type 1 diabetes. The studies of glycemic control in type 2 diabetes has led to some mixed result. In the first trial, ACCORD, the intensive care group had increased cardiovascular and total mortality with no benefit on the kidney endpoints. Similarly, in advanced trial, the intensive care group had no benefit on the cardiovascular outcome. However, there was reduction in the microvascular events and albuminuria was reduced by 21%. In VADT trial, the intensive group had similarly no benefit on the cardiovascular outcomes and also no benefit on the kidney endpoints. Based on these trials and findings, KDIGO had recommended individualized HbA1c target ranging from less than 6.5% to 8% in patients with diabetes and CKD who are not treated with dialysis. In younger patients with short duration of diabetes, high life expectancy, low risk of hypoglycemia and no prior cardiovascular event, we can target for a lower HbA1c. Similarly, a frail or elderly patient with a long-standing diabetes with pre-existing cardiovascular problems or patient who are susceptible to hypoglycemic episode, a higher HbA1c goal may be targeted. Talking about inhibition of RAS, this is the single most effective and proven therapy in patients with diabetic nephropathy. RAS blockade can be done using various drugs like ACE inhibitor, angiotensin receptor blockers, direct renin inhibitors and mineralocorticoid antagonists. RAS inhibition for primary prevention of diabetic kidney disease. RAS blockade studies in patients with type 1 or type 2 diabetes who do not have any proteinuria to assess whether therapy can prevent the progression from no proteinuria to microalbuminuria has shown no benefit. Thus, the use of RAS blockade in normotensive, normoalbuminuric diabetic patient for primary prevention of diabetic kidney disease is not recommended. However, RAS inhibition still continues to be very effective and first-line antihypertensive therapy for patients of diabetes who have hypertension. The importance of RAS inhibition for treatment of diabetic kidney disease in type 1 diabetes have been shown in CAPTOPIL trial, in which type 1 diabetic patients with proteinuria are randomized to CAPTOPIL versus placebo. It was shown that CAPTOPIL reduced the risk for doubling of serum creatinine as primary outcome and death, dialysis therapy or transplantation as a secondary outcome. Similarly, in a study by North American Microalbuminuria Study Group, it has been shown that ACE inhibitor captopril reduces the progression of microalbuminuria to overt proteinuria significantly over the period of 2 years. Thus, it highlights the importance of ACE inhibitors in patients of type 1 diabetes with proteinuria. In IDNT trial, type 2 DM patients with proteinuria and reduced kidney function were randomized to irbesartan versus amlodipine versus placebo. It was shown that irbesartan reduced the risk for doubling of serum creatinine, ESRD or death. The level of blood pressure achieved with irbesartan and amlodipine were same. So it proves that ARB in type 2 DM with microalbuminuria reduces renal outcomes independent of blood pressure control. This is the summary of various renin-angiotensin inhibition trials in type 2 diabetic patients which have all shown positive response in the terms of renal outcome. These are the trials addressing question of therapy with multiple agents that block the RAS. In on target trial, the patients were randomized to ramipril versus telmisartan versus combined telmisartan and ramipril. It was shown that there was no benefit among the 3 arms, though proteinuria reduction was significantly more in combination therapy. There was increase in DDT, that is death, dialysis and transplantation events in the combination therapy arm. Similarly, in VA Nephron D trial, losartan and lisinopril was compared with losartan and placebo. The trial was terminated early because of AKI events and hyperkalemia in the combination therapy arm. Similarly, in altitude trial, the ACE inhibitor or ARB was combined with direct renin inhibitor aliskiren versus ACE inhibitor or ARB and placebo. This trial again was terminated early because of increased adverse event in the combined arm. Similarly, in the Fidelio DKD trial, the finerenone, which is a mineralocorticoid receptor antagonist, was added to maximal RAS blockade in type 2 diabetes patient with CKD, and it was found that treatment with finerenone resulted in lower risk of CKD progression and cardiovascular events than placebo. However, again, the combination leads to significant hyperkalemia and the trial was discontinued. So, based on these evidence from the above trials, there is a strong support for the use of RAS blocking agent in the treatment of patients with diabetic nephropathy. And although RAS blockade with more than one agent may be effective in reducing proteinuria, the adverse event profile, that is hyperkalemia and increased cardiovascular events, and no benefit in preventing ESKD, precludes the general use of combination RAS inhibition in patients with diabetic kidney disease. Coming to the blood pressure control, many observational studies have linked the presence of hypertension to the development of microalbuminuria, overt proteinuria, and declining kidney function. In type 1 diabetes, the appearance of moderately increased albuminuria typically precedes hypertension. But in type 2 diabetes, almost 40 to 50% patients have diagnosis of hypertension before the onset of diabetic kidney disease. Absence of hypertension in an untreated patient with overt nephropathy should raise the suspicion of underlying cardiac disease or some other renal pathology. In a post hoc analysis of IDNT and the renal trial, it was shown that participants with poor BP control at the entry did worse. Also, there was those who achieved better BP control had better kidney outcome during the trials, which highlights the importance of blood pressure control in diabetic patients. In IDNT study, also there was a presence of J-shaped curve such that kidney benefit reached a plateau at systolic blood pressure of 130 millimeters of mercury, and all-cause mortality increased at systolic BP less than 120 millimeters of mercury. So while treating hypertension, we should be cautious not to lower the blood pressure too much so that can negatively impact the patient. ACCORD BP trial also tested the hypothesis that more intensive BP control could be a benefit related to standard BP therapy in around 5,000 patients with stable type 2 diabetes and high risk of cardiovascular disease. The target systolic BP in intensive therapy group was below 120 and the target systolic BP for standard group was below 130. The study found there was no reduction in the rate of primary composite cardiovascular outcome associated with either BP goal. Though there was a decrease in the albuminuria, but that do not translate into reduction in the ESKD events. And also there was increased risk of acute kidney injury and other adverse effects attributable to antihypertensive therapy in patients in whom intensive blood pressure control was targeted. So based on these trials, the KDIGO guidelines recommend that a target blood pressure of 140 by 90 millimeters of mercury for all diabetic patients and below 130 by 80 millimeters of mercury for patients who have CKD and or urinary albumin excretion more than 30 milligram per day. Coming to SGLT2 inhibitors, this is a new class of agent that blocks the sodium glucose cotransporter receptors in the proximal tubule with subsequent glycosuria, which have generated a lot of interest in the renal outcomes in patients with diabetes and diabetic kidney disease. In cardiovascular trials of SGLT2 inhibitors, exploratory results have suggested that such drugs may improve renal outcomes in patients with diabetes and diabetic kidney disease. The first SGLT2 trial dedicated to kidney outcomes was Credence trial, in which around 4,400 patients with type 2 diabetes and urine albumin excretion more than 300 milligram with EGFR of 30 to 90 millimeters of 30 to 90 and who were on stable maximal dose of ACE inhibitor or ARB for 4 weeks were randomized to either canagliflozin or placebo. The primary outcome in this trial was doubling of serum creatinine, ESKD, death due to cardiovascular or kidney disease. The trial found that in patients with type 2 diabetes and kidney disease, canagliflozin significantly reduces the risk of kidney failure and the cardiovascular events. The other SGLT2 inhibitor trial that is dedicated to renal outcome is DAPA-CKD, in which again around 4,000 people with EGFR of 25 to 75 with proteinuria of 200 to 500 milligram per day were randomized to either 10 milligram per day of dapagliflozin and placebo. It was found that the composite kidney or cardiovascular outcome or death was significantly lower with dapagliflozin than the placebo. In this trial, only 2/3 of patients had concomitant diabetes. Rest of the patient, they were CKD but they do not have diabetes. Thus, it showed that dapagliflozin improved kidney and cardiovascular outcomes in CKD patient irrespective of diabetic status. So this is the summary of SGLT2 inhibitor trials with renal outcome. Some trials have renal outcome as primary outcome, some trials have renal outcome as secondary outcome, but all have shown positive outcome, positive results in terms of kidney outcomes. So based on these studies, SGLT2 inhibitors are advised, are recommended to in patients with type 2 diabetes and CKD. Those patients who have got EGFR more than 30, especially who have got significant proteinuria and concomitant heart failure, these patients should be given SGLT2 inhibitor. After ruling out potential contraindications like genital infection, diabetic ketoacidosis, foot ulcer, immunosuppression, low-dose SGLT2 inhibitors with proven benefit can be started in such patient. We should educate the patient regarding the sick day protocol while prescribing SGLT2 inhibitor. Somebody who is sick, acutely ill and who are prone to dehydration when taking SGLT2 inhibitor are prone to development of diabetic ketoacidosis. Similarly, SGLT2 inhibitors has to be stopped 2 days prior to a elective surgery and during the immediate post-operative period. Similarly, we should advise patient who is taking SGLT2 inhibitor for meticulous food care and meticulous perineal hygiene. These are the various adverse effects which are seen in various trials involving SGLT2 inhibitors, which are diabetic ketoacidosis, urinary tract infection, genital mycotic infection, bone fracture, limb amputation, and hypoglycemia. The prescribing physician should be alert of these adverse effects associated with SGLT2 inhibitors. The last domain of treatment of diabetic kidney disease include cardiovascular risk reduction, which includes lifestyle modification involving weight loss, increased physical activity, smoking cessation, low sodium intake, low protein diet, which have been discussed in volumes in the preceding talks, and also a diabetic patient who have dyslipidemia should be managed with statin. So take home message for my presentation would be all diabetic patients should be screened for diabetic kidney disease by detecting urinary albumin excretion and measurement of serum creatinine that is converted into eGFR, not merely measuring serum creatinine, and the development and progression of renal disease in diabetes can be reduced and slowed through appropriate glycemic control, optimization of blood pressure, RAS inhibition, SGLT2 inhibition, and reduction of cardiovascular risk. Thank you very much for your kind attention.
Diabetic nephropathy and diabetic kidney disease have been very lucidly discussed, and few of the slides were just clinical calls. Very nitty-gritty things cleared here. So even if there are any suggestion or any query from the house, it's open for us.
Felicitate attorney. So request Dr. Thank you. That's quite long, but I think this is quite interesting. So may I request Dr. Ajay Kumar Sinha to moderate the session, and the topic will be on updates on resistance and hypertension. The speaker is Dr. Ashok Kumar. What is the topic?
Thank you, the team Sinsan, for inviting me and giving me opportunity to be a part of the program as a chairperson. A very good afternoon, or rather good evening. I am happy to see our legendary Professor and clinician Dr. Professor P.K. Gawal here, sir. My warm regard to him. Thank you, sir, for coming. Thank you, everybody. So, this is the last session, and we know that the prevalence of hypertension is very high in India, and particularly if a person is diabetic, the hypertension becomes more important and sometimes more resistant to treat. And we also know with the evidence that if the person is having hypertension and diabetes, it's better to treat hypertension first than diabetes to prevent complications. So without taking much of time, I invite Dr. Ashok Kumar, clinician in cardiology, DM cardiology, interventional cardiologist. He will take us through to what is the evidence and what is the updates on resistant hypertension in the year 2022. Because we know that in clinical practice we have to rely on the evidence, and the evidence is coming through the two sources, either through the professor and clinician source or through the trial, the randomized controlled trial. And now we know in non-communicable disease, in the last 30-40 years, the clinical experience by professor has gone down. It's called power C. So we have to depend upon the double-blind placebo-controlled trial and the other evidence, which is coming from mostly from the Western sources. Now they have started in India. So I will over to Dr. So to take us through. This is a very important topic. Thank you.
Cause of CKD, that is hypertension. So any hypertensive patients that is not adequately controlled, now the evidences say that you must rule out three things. First, do BMI to rule out obesity or metabolic syndrome. Second thing, do HbA1c to rule out diabetes. And third, you must do kidney function test to rule out CKD. So these are the main comorbidities that hampers the management of hypertension per se. So this is the pathway through which I will go across my discussion. First thing, a definition of resistant hypertension. And a different society is already confused regarding defining what is resistant hypertension. First and foremost definition comes through European Society, and that says if the blood pressure is not adequately controlled on three drugs of different class, that will be labeled as resistant hypertension. But they were silent about which three drugs will be. Then came NICE UK, and they have redefined, and they said there should be 3 drugs in which one must be diuretics, because there was a study way back 2004 that has clearly mentioned that most common cause of resistant hypertension is volume overload and even subclinical hyperaldosteronism. So diuretics, there must be one diuretics, and second, if not control, MRA will be the second option. But AHA has further elaborated the definition by including in those 3 drugs there must be one CCB, one RAS inhibitor either in form of ACE inhibitor or ARB, and one must be diuretics, either thiazide diuretics or thiazide-like diuretics in the maximum tolerated dose or the dose that has been used in guideline. Another line AHA has added, if the patient, even the blood pressure is well controlled, but the patient is taking 4 drugs, that should be labeled as resistant hypertension. So what are the risk factors for resistant hypertension? Patient characteristics is the first and foremost thing. Because we cardiologists face that about 40% of patients become non-compliant after 1 year of therapy. And in previous talk, Dr. H.K. Verma has already mentioned that in India, only 10% of a patient is adequately controlled. So in our country, it is hard to think about the incidence of resistant hypertension, how much it could be. But different study has shown 10 to 20% of the patient is being labeled as resistant hypertension. Second risk factor is medication non-adherence, that might be further so many of cause of medical non-adherence. Even elderly populations, they forgot to take the prescribed medicine on prescribed time, and many a time cost even multiple pills, and on the multiple time they forgot to take. Improper BP management technique is also one of the most important thing, because there are many a time we will see the physicians inertia. They hardly believe in up-titrating the dose of antihypertensive. Further, white coat effect, and in our own Indian study, we have found that about 42% of patients were misdiagnosed, either it was masked hypertension or white coat hypertension. Obesity, of course, is a very important factor that leads to resistant hypertension. Lifestyle factor, and sleep disorder is also a very important cause. As we are talking time and again about the diet and exercise, but we forgot that 6 to 8 hours sleep is as important as exercise is. So clinical incidence and prevalence of resistant hypertension, global and Indian statistics. So global burden of disease, according to 2019 study, there was about 86% increase in the number of adults affected by high systolic blood pressure from 1990 to 2019. So almost it increases to doubles, and the prevalence of resistant hypertension among hypertensive individuals varies from 10 to 20%. It depends upon the definition by which we are labeling it as resistant hypertension. So by different definition, the incidence and prevalence of resistant hypertension differ. This is the Indian statistics. Now coming to the impact of metabolic syndrome on resistant hypertension. So this is a cross-sectional study of not very large population, but it has shown that metabolic syndrome prevalence of 73% in resistant and 60% in mild to moderate hypertensive patients. And we have seen in different meta-analysis that has shown that hypertension per se include about 70% of hypertensive have some other comorbidities. They rarely came alone. So effect of metabolic syndrome on resistant hypertension, that has been very well elaborated by Dr. Ved Prakash. So I am going to skip this slide. So two-way relationship between resistant hypertension and metabolic syndrome. And when the study was done, although the study population was very less than 20 even, so they have shown that metabolic syndrome exhibited greater level of muscle sympathetic nerve activity, and even there was a greater carotid to femoral pulse wave velocity in patients with resistant hypertension. Coming to the diagnosis is very important, because we have first and foremost thing is to rule out the pseudo-resistant hypertension prior to moving forward for the therapy of resistant hypertension. So important factor in the evaluation of resistant hypertension is the patient history, including lifestyle characteristics, is very important, and we have to rule out certain added medications. Many a time you will see patients is taking NSAIDs for pain or arthritis, and that is going to reduce the efficacy of prescribed antihypertensive medications. Many medications are there like tacrolimus and all, even some herbal medications that are quite frequently used in our population, and that interacts with the antihypertensive medications, and that may be a cause of failure to achieve the goal. Physical examination with focus on presence of hypertension mediated organ damage. By doing this, looking for the target organ damage, we can order for home BP monitoring or even ambulatory BP monitoring to diagnose undiagnosed, like masked hypertension and white coat hypertension, we can diagnose by those methods. Some laboratory tests to detect electrolyte abnormalities, and the nature and dosing of the antihypertensive treatment must be individualized. When many a time you will see patient is taking amlodipine and selenodipine, but that these combinations are useless, so that must be taken care. Many a time patients himself or herself used to take medicine from other family members, because my medicine is not so effective, so they used to take some other medications also. So confirmation of treatment resistance by out of office BP measurement, and this is important, very important, because when you are going to involve the patient in the treatment plan, that is going to convince the patients in a better way, confirmation of adherence to BP lowering therapy, and this could be done very easily in our part, just by admitting the patients for 2 to 3 days and monitor the compliance of the patients and measure the BP. That could be done very easily, and that is not very cost involved in those things. So evaluation of resistant hypertension according to WHO: confirm treatment resistant first, then exclude pseudo resistance, then access for the secondary hypertensive that can be treated, and those are the things like primary aldosteronism. Many a time we see subclinical primary aldosteronism, and that hinders in the controlling of blood pressure. That's why adding low dose of MRA controls BP in a very good way. Renal artery stenosis, pheochromocytoma, Cushing syndrome, obstructive sleep apnea, coarctation of aorta should be ruled out, and like target organ damage, we have to do fundoscopic examination routinely. We have to see by ECG and echocardiography the ventricular hypertrophy, and by doing ACR we can see proteinuria, and by doing AVI we can see peripheral artery involvement. So these are the different guidelines and BP threshold. By this, the prevalence of resistant hypertension increases. So stick on any guideline and follow that. Management as per the latest guideline. What so? So resistant hypertension is a complex condition and requires a multimodal approach to achieve BP control. And most patients can be managed with medication optimization and the use of combination therapy or better to say single pill combination therapy that is going to improve the compliance as well as control. So resistant guideline of Hypertension Society of India, patients with resistant hypertension should be referred to a specialized hypertensive clinic after evaluation of the level of compliance and aggressive salt restriction, because only salt restriction by reducing the salt intake by less than 5 gram, we are going to reduce the systolic BP by 5 to 8 millimeter of mercury. And one should look for the secondary hypertension and treat those. So this is the algorithm to manage. Step 1 is to reduce the salt intake and maximize lifestyle intervention by promoting sleep for more than 6 hours, overall dietary plan, weight loss, exercise. And after that, substitute optimally dose thiazide-like diuretics to either indapamide thiazide-like diuretics, indapamide and chlorothalidone. And if not controlled, we can add MRA, and still BP is not under control, then we should check for the heart rate. And that has been shown very clearly in Pathway 2 trial. If the heart rate is high, bisoprolol has shown good result, whereas if the heart rate is less than 70 and BP is not under control, in those situations MRA has a better result. And among alpha agonist, moxanidine is a preferred one. If still not controlled, we can add hydralazine 25 mg thrice daily, and if still not controlled, we have minoxidil. And if still not controlled, we have two devices like renal sympathetic stimulation and ablation and baroreceptor stimulation that can be helpful. So according to ESC, reinforcement of lifestyle measures, especially sodium restriction, addition of low dose spironolactone to existing treatment, or the addition of further diuretics therapy if intolerant or if not indicated. Many a time in CKD patients, we cannot use thiazide or thiazide-like diuretic. In those situations, we can use loop diuretics, and the addition of bisoprolol or doxazosine is another options. So these are the certain situations in which what we can choose for the management, like for edema resolution, volume control, we can use thiazide, chlorothalidone or loop diuretics. For heart rate control, beta blocker is there. Renin and aldosterone level is low, then low salt diet likewise. So metabolic syndrome and hypertension. Patients with hypertension and metabolic syndrome has high risk profile, and the treatment of metabolic syndrome based on the change in the lifestyle by reducing weight. And the treatment of hypertension or metabolic syndrome should include BP control as in the general population, or some molecules are preferable that are metabolically neutral like CCB and even ARB like telmisartan, or among beta blocker, nebivolol has shown some favorable effect along with carvedilol. So treatment of additional risk factor based on the level of overall cardiovascular risk. And current guidelines do not specifically address the management of resistant hypertension in patients with metabolic syndrome. So we have to follow the guideline as of normal population. So considering the increased risk of developing diabetes in these patients, anti-hypertension treatment should focus on the inhibition of renin-angiotensin system. As we have seen that ACE inhibitor has shown some reduction in the incidence of diabetes, so that could be preferred in these situations. Though there has been increasing interest in combination strategy for anti-hypertensive agent in resistant hypertension patients with metabolic syndrome to reduce the pill burden. These are the research and challenges that is the need of the hour, and knowledge and prevalence of the resistant hypertension is urgently needed, and reducing the BP target in the general hypertensive population increases the prevalence of resistant hypertension, and documentation of the prevalence and the prognosis of resistant hypertension needs to be reconfirmed, and a better understanding of optimal BP target for resistant hypertension is needed. To summarize, prevalence is about 10 to 20%, and resistant hypertension is a complex condition and require a multimodal approach to achieve BP control. And resistant hypertension is a complex condition, requires a multimodal approach to achieve proper both BP control. And current guidelines do not specifically address the management of resistant hypertension in patients with metabolic syndrome. Thank you.
Thank you, Dr. Ashok, for your brilliant presentation. And almost you have covered all the things about the various steps of management of resistant hypertension. And at the end, you have said that if the drug is not controlling the blood pressure, take the support of the endovascular intervention. So this is the scenario. So the house is open for discussion if any question. Admitted, one in D ward and in E ward. One patient is having the creatinine of 2.9, the another person is having the creatinine of 5.9. Both are diabetic. And we have tried everything. Still his blood pressure is 190 by 110. Nitroprusside, NTZ, the calcium channel blocker with huge dose, diabetic in huge dose. So sometimes it becomes frustrating to the student at least. The postgraduates, they say, sir, नहीं हो रहा है कंट्रोल, सब कुछ दे दिया, अब क्या दें? चलो भाई MRA दे दो कुछ, potassium देखते रहो. So how do you think that if the patient, mostly patient doesn't complain, they are happy. So it's a kind of symbiosis between patient and attendant. The patient doesn't ask, ठीक है, हम ठीक है. The average Bihari patient who is in medical college, they do not ask what is a guideline or what you are doing. But suppose a person asks that we have undergone everything, what do? You will have something. I say dialysis, you go for dialysis. So what do you suggest? Do you suggest that in this patient, if somebody asks, go for endovascular intervention because simplicity HTN has not favored? So what you do or nephrologists do in a situation where the blood pressure is not reducing, even after you have applied all those things? Dr. Pritpal is here. So any comment? We are struggling every time. There are two clinical conditions where blood pressure makes us vexed. The one is pregnancy, that is a separate issue. The other is CKD. So, what is the solution of it?
Additional drugs or any intervention. Two issues are seen in almost all the cases. One is adherence to the drugs, and another is salt and water retention, salt and fluid retention. So one thing in OPD basis, we have to ensure that patients are taking drugs regularly. Most of the times they are either not taking or modifying on your own will. Another thing is they do not take care of fluid restriction. They are taking 3 liters, 4 liters, while we advise only 1.5 or 2 liters, also like that, and salt restriction. So these are two things which must be taken care of, and if these are taken care of in almost 95 to 99% cases, you will get the patient controlled with their blood pressure, whether it be 5 drugs or 6 drugs.
Normally, so, still we have two patients. One is D, one is E. We are giving 20 milligram thrice the diuretics. The 20 milligram defiant retard 3 times daily. 60 milligram. We are giving the ACE and ARB, keeping in mind to take care of the potassium. Potassium is still in the side 3 or 4 or something like that. We have not managed, according to Dr. Ashok, has prescribed the stepwise approach. But the and we have also given the NTG. Sugar BP was high. Still in the morning ward round, the blood pressure was around 180 by 106. So what to do in that situation?
Controlled with NTG and all other drugs to the maximized doses. Like we use arterial dilators and all those apart from NTG. And if we maximize, we can control it.
Yes, it takes time.
Sometimes NTG at the higher level, higher doses also. But we get rid of these things.
So,
most of
and I have also forgotten. I have
Being diabetic in proper dose, even though our patients, particularly elderly patients and those who are suffering from CKD, they complain dryness in mouth. and they often used to take sip of water, and it went more than 3 liters per day. And without reducing the volume, we cannot control. First. Second thing about MRA. We refrain to use MRA if the serum creatinine level is more than 2. But in future, we can, because in market in coming days, non-steroid aldosterone antagonist is going to come in market.
Doctor was telling about this, and the clinical outcome, and the potassium, hyperkalemia is also less with neuron
Compared to
which is a
older.
non-steroidal.
Yes, regarding simplicity. So now simplicity spiral is coming with great way, and that is going to give you the better result.
So I think this
Ashok, I think last, may I request Dr. Ajay Kumar to felicitate Dr. Ashok.
Yeah.
For his So now I request Dr. Agarwal to felicitate Dr. So we have come to an end of our session one. Now I request my colleague Mr. Baga to give the vote of thanks, and then you can discuss.
A very good evening, and myself Satwan Singh Bagga, as National Business Manager based at Pune, would like to, on behalf of Sinsen Pharma, would like to propose a vote of thanks to concluding day of the meeting of MD India Forum at Patna. My heart fills with a lot of gratitude and respect to our eminent post-director Dr. B.K. Agarwal for giving his guidance and inspiration to kick-start this MD India Forum. And I would like to express my sincere thanks to our honored and admirable speakers, Dr. Sajjad Ehsan, Dr. Shamshad Alam, Dr. Anil Jaiswal, Dr. N.P. Verma, Dr. Ashok Kumar, Dr. Ramesh Kumar, and Dr. Ved Prakash for delivering excellent outline of the topic and aligning with the core theme of the meeting. And I would like to thank our honored moderators, Dr. Ajay Kumar Sinha, Dr. H.K. Singh, Dr. Subhash Kumar, Dr. Pritpal Singh, and Dr. Ashish Kumar Jha, for not only sparing their valuable time to grace this MD India Forum, but also for their value-added clinical discussion. And also to our esteemed delegates for providing real clinical insight coupled with their experience to this meeting. Now, I'm sure this clinical discussion happened in this meeting will help every one of us to take challenges of addressing metabolic syndrome to its complexities. You have provided us with valuable support and enriching the scientific endeavor of Sinsen Pharma. Now, we also look forward to your valuable participation in season 2, which will be announcing very shortly. And this support and endeavor of Sinsen Pharma initiative will go a long way. This is just the beginning, and we look forward to your valuable participation in this. Thank you so much once again, and have a great time. Thank you.
All faculty.
Sir, thank you so much, sir. Thank you. Thank you.